because I can assure you that any time a Scotsman arrives in Liverpool, there's either a party or a fight. So hopefully we'll break that tradition today. So, I bid you all good morning. Right, my name is Robert Mitchell-Thane. I'm here from the PBC Foundation. So I'm here to talk about the value of patient participation in stratified medicine. To do that, I need to give you a little background. A lot of what I'm going to say will dovetail beautifully with Dr. Burton and her presentation, but I just need to give you a little background. So I'm going to speak principally about PBC and our experience within that, particularly within stratified medicine. So I come from the PBC Foundation. My mother has PBC. She was diagnosed 21 years ago. Now we as an organisation, we offer principally support services to patients. So we started in 1996 in the UK. We currently have over 9,000 registered service users. However, they are from the UK plus 65 other countries around the world. We are about to launch an international website which will go live in 16 languages of the world. And what we offer are leaflets, what we call a compendium. And the compendium is a 60-70 page booklet which would answer any question that you would have if you were diagnosed with PBC. And that's really important to take on board because stratified care is certainly part of that. Now, in terms of what Dr. Burton was saying, one of the key services that we provide, we go around the UK. I'm recently back from Israel, having been funded to go over there, but what we do is self-management sessions where we'll spend, depending on budget, 1 day, 2 days, or 3 days looking at the emotional and psychological self-management of living with an incurable condition and how that will affect your day-to-day symptoms and how that will affect your long-term management of the condition itself. And this is hugely important when we look at the implications of PBC, which we'll do very shortly. We have a telephone helpline, we have an email service, and we have a patients forum. Again, which is rather urgent in terms of stratified medicine, getting the message out there. We have the dubious task of not only educating the public, but we also go around the UK and we educate GPs and nurses with regard to PBC and what it actually means for patients. And then finally we do advocacy and campaigning. So PBC is an autoimmune condition. Now I'm going to take you back to what we call the bad old days. So PBC used to stand for primary biliary cirrhosis. And so the patient would go to the doctor and the doctor would say, okay, you have something called primary biliary cirrhosis. But actually, well, you don't have cirrhosis, which is a bit confusing for the patient. And even worse days were when the patient was talking to friends, family, carers. They'd say, well, yes, the doctor said I've got something called primary biliary cirrhosis. Yeah, I don't have cirrhosis. And before you even ask, no, I don't bloody well drink. And that would be how the conversation went. And the reason I'm telling you this is that in an initiative that started last year, patients themselves, patient advocates, and then healthcare professionals got together and they were faced with the question, if there's an initiative to change the name of PBC from primary biliary cirrhosis to primary biliary cholangitis, would you support it? And around about 80% of each of those groups supported it. So, as of 2015, PBC is now known as primary biliary cholangitis. Why am I telling you this? Because it is an example of the power when patients, patient advocates, and medics come together to focus on one idea and make it happen. So this is just one example. This is worldwide. We're waiting on WHO to ratify this, and it will happen, but it's gone through, and it's just an example of what can be done. So, primary biliary cholangitis, it's an autoimmune condition. It's a chronic cholestatic liver disease. It affects 1 in 400 women over the age of 40. It has increased mortality and morbidity. There's no cure. There's only one treatment for PBC, and that is ursodeoxycholic acid. So you'll read it as UDCA. I will talk about urso. We are completely inadequate in terms of our understanding of its etiology, and there's an estimated 20,000 cases in the UK. So it's enormously underdiagnosed in the UK. So, because it's autoimmune, we know that there are links to other autoimmune conditions. So when we look at the risk, or what we understand the risk to be, we know that 42% of people diagnosed with PBC are at risk of having at least one other autoimmune condition. So again, in terms of stratifying or personalising the care to each patient, we need to be aware of those facts. So it's just something that I'm sharing with you. So, we spoke about URSO, or UDCA, ursodeoxycholic acid. Now, if you're diagnosed with PBC early enough, if you're given URSO at the correct diagnosis or correct prescription, and then you respond biochemically to that URSO, then, as you can see on the top line, you are with the general population in terms of life expectancy. But if you're not, and you don't, then you most certainly don't. So we know already that in terms of PBC, we already have two very, very separate PBC journeys, and therefore two very individual care paths that need to be put together. So within PBC, there are many possible journeys, and even those intermingle. So you can be asymptomatic with your PBC for the whole of your life. You can be symptomatic, and yet your condition doesn't actually progress. You can be symptomatic to the point of liver transplantation. So for example, people who have irretractable itch will be considered for liver transplant. Then you have URSO response. So URSO response is to do with the biochemistry within the liver. So you're looking at your liver tests to measure whether or not you're responding to URSO. If you do respond to URSO, as we say, you rejoin the general population in terms of your life expectancy, but if you don't, you don't. You can still have URSO response, and yet the cell change within the liver, the histology, will progress, which means that you will still possibly go on to eventual liver transplantation. Okay? And then we have, as you saw on the lower line, much, much worse expectance when you are a non-responder to URSO. And so at UKPBC, we've come up with this 50 at 50 idea. And the idea is that if you're diagnosed under the age of 50, you have a 50% chance of going on to need liver transplant. And that's different from what happens when you're above 50. So already we're starting to look at, as patients, as medics, and as advocates, the different pathways that are within PBC. So when we look at end-stage disease, we're looking at ultimately death. We're looking at jaundice, coagulopathy, encephalopathy, ascites, and varices, all of which are symptoms of general advanced liver disease. If your PBC is judged not to progress too far, then you have the general symptoms of PBC themselves, which are generally fatigue, which usually goes hand in hand with a cognitive impairment. And then, of course, there's pruritus, which is an itch under the skin with no visible signs. And if you're very fortunate, then you can have your PBC all your life and be completely asymptomatic and not progress anywhere. So we're definitely very absolute lines in terms of where your PBC can go. So the UK PBC is a consortium of clinicians, patients, advocates, and industry. And we're looking to work together principally to find out who responds, who doesn't respond, why they respond or why they don't respond, and what we can then do to treat URSO non-responders. As we said earlier, there is only one treatment for URSO, and that is URSO. Only one treatment for PBC, sorry, and that's URSO. Thereafter, as a patient, you can be told, well, actually, we need to sit you down and tell you that as you stand at the moment, you're an URSO non-responder. And that's as much as they can tell you, which isn't good enough. So we're looking for more novel therapies, we're looking for better ways to treat PBC and to slow down its progression. So we want to transform the lives of PBC patients, we want to support the development of better therapy, and we want to generate economic opportunity within the UK. So a little history about the PBC, UK PBC project. It was started in an idea from MRC, which was a £6 million stratified medicine programme. And the idea was to identify who responded, who didn't, and why. And we found, to begin with, that with PBC, there's around about 24, 25 SNPs in the DNA that are pertinent. So we now know that there is a genetic predisposition to PBC itself. But what we want to find now is there a genetic predisposition to URSO response? Is there genetic predisposition to needing transplant? Is there genetic predisposition to going on to develop these debilitating symptoms? So it's UK-wide. It uses all the centres. It's multi-centred. All the patient groups are involved, and there is a national trials platform. So again, anyone around the UK who is judged to be a non-responder can get involved and is educated in terms of what that means and what the implications are. So I'm not entirely sure you can make this out, but what I wanted to do was just highlight the approach that has been incorporated into UK PBC. So when you look at the actual steering committee, which directs the whole project, you will see that there are 2 patient representatives on there, as well as indication from clinicians and industry as well. The UK PBC Access Group. This is a committee which is designed to allow access to our database. We have a database of now 6,600 plus separate DNA samples from people affected by PBC, which is the biggest in the world. But what we want to do is open that up and open up the access to that. But again, there's a patient voice on that committee to make sure the work and the suggested research is actually pertinent to patients and important to improving their quality of life. So just to give you a shape of the structure itself. So patient involvement. What does it mean? Well, we as an organisation, we've helped recruit through our magazine, through our website, through these workshops and sessions we host around the country, a cohort of 6,000 plus. So we're now at 6,600. We're involved as patients in the steering group and the access group as well. As well as that, because of the cooperation and because of the level of partnership within UK PBC, the foundation has been involved in the BSG guidelines, yes? The BSG guidelines for care of PBC, and that has the stratified care pathways all highlighted within them. And we hoped it would be this year, but we're looking to spring 2016 for them to be released. We have been down to NICE to speak about OCA. Obeticholic acid is potentially second-line therapy for PBC. So it's gone through all its tests. We're just waiting for it to be approved and for it to be released. Again, we're looking at second quarter of 2016. But as a patient organisation, we've been invited to NICE to let them know about the second line, the need for the second line, and why within stratified care it's important to have. And finally, the Liver Transplant Patients Consortium. Again, this is highlighting to NHSBT in terms of liver transplantation, the needs of patients who have PSC, who are non-responders, and who have a much, much more urgent need for care. And what's that patient involvement brought us? Well, we have increased involvement in research. At over 6,500 is the biggest PBC cohort in the world, which has generated the biggest answers in terms of the genetic study in Cambridge with our 24-25 SNPs. We have increased awareness of novel therapies. So again, now if a patient is told that they're an URSO non-responder, they know that there are new medications on the way. They know that there is more research now than ever before within PBC. And ultimately, that knowledge in itself will give them hope. That they're not just left to go and fester, that there's actually work being done, and they have a chance to slow down the progress of this potentially fatal condition. We have increased awareness of different disease journeys. So patients, again, have an awareness of where they could go potentially, what their risks are, and what they can do to help themselves. They have an awareness of the different healthcare pathways. So again, treatments, investigations, what needs to be done to make sure that they are looking after themselves. Increased confidence in speaking with healthcare professionals. Dr. Burton, you alluded to this. Patients and doctors need to come, the days of medicine being done by doctors to patients are long gone. But we need to inform and educate the patients to make sure they're asking the right questions at the right times and making sure they look after themselves. So we're looking at a cohort around the UK of 6,500 expert patients. And because they're expert patients, they're going to be involved, they're going to be proactive, and they're going to be taking a huge part in their own personal care. So that's me. Run out of time? Just before the silence, which we'd be pleased to. So I will invite any questions probably after, I think is a fair thing. But just to thank the UKPC Consortium for giving the figures, particularly Professors Jones and Mills. Thank you for your attention.